Hello, and thank you for joining today's webinar. We are going to be getting started in just a moment. If you'd like, you can go ahead and share in the chat where you're joining us from today. We'd love to know where you are. All right. So we appreciate you joining us today. We are going to get ready to begin. This webinar is being recorded and it will be available via the Sigma repository within a few business days of recording. Following the presentation, if we have time, we'll have a question and answer session. And you'll see on your Zoom webinar control panel that you can send a message through the Q&A feature. This is where you can type in any question you'd like to pose to the presenter. Be sure to hit send so that the message makes it to us. Please use the Q&A for questions and the chat feature to interact with other participants. We'd like to thank our speaker for sharing their expertise with us today. Of note, thoughts and views expressed are that of the presenter and do not necessarily reflect that of Sigma. Our speaker today is Dr. Rhonda Laws. Dr. Laws is a highly respected nurse educator, clinician, and leader with more than 30 years of experience in nursing and over 2 decades in higher education. She currently serves as an active faculty member in a Bachelor of Science in Nursing program and as the Chief Nursing Officer at Lecturio Nursing. Dr. Laws holds a PhD in educational psychology with a research focus on academic resilience, self-efficacy, mindset, and evidence-based strategies for teaching and learning. Her expertise in these areas has informed her dynamic and student-centered approach to nursing education. In addition to her academic and clinical roles, Dr. Laws is nationally recognized for her extensive experience in NCLEX preparation. She spent years equipping aspiring nurses with the knowledge, skills, and confidence needed to pass the NCLEX RN exam. Through engaging lectures, innovative teaching methods, and a deep understanding of test-taking strategies, Dr. Laws has helped thousands of students navigate one of the most challenging milestones in their nursing careers. Her dedication to student success and passion for nursing education continue to shape the next generation of compassionate, competent nurses. Dr. Laws, I will turn it over to you.
Thank you. Oh, you guys, I'm so glad for those of you that got to come back. And those of you, this may be your first session, but don't worry, it is all been recorded. So let's get familiar. Oh no, I sent you guys some messages and it's only going to the host panel. Sorry about that. Well, here's what I said. The most important thing, because that's a really long introduction, just know that I really do love nursing students. This has been the highlight of my career, is to be able to teach nursing students, because nursing school was really hard for me. I got super discouraged sometimes. I felt like I couldn't make it through. So I always want every nursing student to have faculty that believe in them and want them to do well. So I want each of you to be successful. And if you are here spending extra time trying to be successful in nursing school, you are my favorite kind of nursing student. You're doing everything you can. So that's all we missed. Now, I want to see if you can find the emojis. Can you guys find the emojis on in Zoom? Sometimes people can send them. Can you find those? If you can, just go ahead and send us some emojis if you can find it. Oh, there you go. Good deal. All right. Super cool. You got it. Oh, look, double emojis from Joseph. Thank you. That's very exciting. All right. So Pharm doesn't have to be scary. The most important thing you can do is think about how you're going to keep your patients safe by knowing if it's the right time to give a med, if it's doing what it's supposed to do, or if the patient's having any adverse effects. So no matter what people have told you, Pharm doesn't have to be so scary, I promise. Now, we've given you some tips and some strategies last week, and I want to review a couple of those. But first of all, I just want to remind you that we are really excited to be the exclusive NCLEX preparation partner for Sigma. So that is a huge honor that they gave us, and that's why we're coming together and partnering with these student events. Now, Sigma has lined up lots of events for you, and we'll make sure that you get all the dates, and they're all meant to help you in nursing school. So we're so excited to be partnering with them, and we want you to be able to take advantage of all the webinars we have because they're free. Now, Sigma, if you're not familiar with what Sigma is, it is an incredible nursing society, and you either join when you're at the end of your nursing school, or you can join as a community leader after you graduate. So it's something for everyone. I've been a member for over 30 years. It is my favorite nursing organization. So I want you to keep that in mind and to think about it. Now, on this next page, we've got this slide up here. You'll see that I've got a QR code. If you have an Apple phone, yours is on the left. If you have an Android or a Google phone, it's on the right. I want you guys to scan this. If you would help me out, this would really help me out with my boss. If you would scan this, it's a free app from Lecturio. Now, here's what you get. First of all, you don't have to give it your credit card at all, but while you're scanning this, let me tell you what you're going to get. This is going to take you to the App Store so you can add it. You're going to get over 250 free video lessons. You're going to get over 500 practice questions. You're going to get another 3 free video lessons per course so you can try it and see if you like it. And you're going to get this smart spaced repetition quiz. That is a really fancy way to say we make digital flashcards for you, and they really help you be successful. My Patho students just started using these, and their grades went up exponentially. We had 69% fewer failures on the test just from using that. So go ahead, if you wouldn't mind, if you would download that app and you get that set up, you would really help me out, because I want to go back and say, hey, I hung out with these students and now they're part of our family because they've joined our app. And remember, there is not a charge for that. It's all free, and you don't have to give your credit card, because I hate those things. When I know I always forget about those. So you've got it all set up and ready to go there. So if you wouldn't mind, that would really help us out, and we'll be sending you lots of free stuff if you're signed up for the app. Now, we're going to start with the endocrine system. Now, we did last week, we did looking at insulins and things like that. And now I want to talk about a type of medication that we give a lot of, and it's called corticosteroids. So these are drugs that mimic what our endocrine system normally does. Now I'm thinking about the HPA axis. That's the hypothalamus, the pituitary gland, and the adrenal gland. And how that works is the hypothalamus sends a message to the pituitary gland, and the pituitary gland sends a message to the adrenal gland. Now, this is going to help you studying corticosteroids understand things like Addison's disease and Cushing's syndrome in your med-surg classes, but we give so many corticosteroids in the world. I want you to be able to know what are the dangers and the benefits of this medication, because your endocrine system does all this, right? It's got hormones, it's got receptors, it's got target cells. It does some super cool things. And sometimes people feel like, oh, this is so complicated, I'm never going to get it. Actually, you really can get it. It is not that hard. It all follows rules. So after today, you'll understand the rules and you'll be able to master all of the endocrine system issues. So you might be thinking, why are we doing all this endocrine stuff? I thought this was supposed to be Pharm. Well, when we go through this together, you're going to understand how corticosteroids work, and I'm saying corticosteroids because they come from the cortex of the adrenal gland. So that's one important point. And I want you to think about the side effects of these medications, and then you'll understand what happens in people like Cushing's disease that have too many corticosteroids, or Addison's disease, whose adrenal gland is given out and it doesn't work. So let's get rolling. I always want to use your time well, and that's why we're going over this. Now, if endocrine was a football game, see, I live in Oklahoma, and football, I'm telling you, sorry about that. I just dropped my lamp off. No worries. We'll get that later after we're done with this. But we live in a football world where even our weather man tells football based on what's going to happen for the weather for the football season. So if you are not familiar with the game of American football, you have a coach who's on the sidelines, a quarterback, he's the guy who throws the ball, and then a receiver, the guy who's supposed to catch the ball. Now, we talked about the hypothalamus, the anterior pituitary, and then the receivers. So the coach is the hypothalamus. That's in your brain. This is the one that's constantly, bzz, 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 bzz. Your hypothalamus is getting information from your body, right? Everything comes from the outskirts of your body in through your nerves to your spinal cord up to your brain. So that's how your hypothalamus is collecting information from all over your body. Now, the hypothalamus starts sending in the plays or the signals. In this case of corticosteroids, it sends it to the anterior pituitary. Okay, so the hypothalamus gets information just like the coach watching the game. They send the signals to the anterior pituitary. In this case, if you're familiar with American football, that would be the quarterback. Then the quarterback is going to send the message down, or the football, to the receiver. Now, there's lots of receivers in the endocrine system. It'd be the thyroid, adrenal glands, reproductive glands like your ovaries or testes. But in this case, we're talking about corticosteroids. We're going to focus on those that go to the adrenal gland. So you'll hear me using a lot of repetition because you and I are studying together. So the coach is the hypothalamus. The quarterback in this case is the anterior pituitary. The receiver is the adrenal glands. Okay, so hypothalamus, anterior pituitary sends a message to the adrenal glands. This is important as you kind of want to study what we're doing. So that hypothalamus, it's right in the central of the brain. It is the main link between the endocrine system and the nervous system. So this is where the pituitary gland cells get controlled. So it's going to produce these chemicals. They'd either tell the anterior pituitary to put out more or to put out less hormones. That's why it's the hypothalamus, or kind of like the coach. Now, the pituitary gland is it is bossy, 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 bossy. The pituitary gland makes tons of hormones that control lots of other endocrine glands. So the hypothalamus is the one that tells the anterior pituitary what to do, and then the pituitary gland bosses around the rest of the team on the endocrine glands. Now, it's not a very attractive gland. Look at it there, right? It's not very attractive, but you've got the anterior lobe and the posterior lobe. Not very cool names either, but there's two lobes to the pituitary gland. We're going to deal predominantly today, mostly today, with the anterior lobe. Now, before we go on any farther, I've talked about the first one, the second one, and the third organ. Can you name those in your head without looking at your notes? See if you can name what those organs were, these three players that we talked about in the endocrine gland. Okay, now if you were able to name all three, and that would be the hypothalamus, the anterior pituitary, and the adrenal gland, give me a 1, right? Give me a 1 in the chat so I know how many of you were able to do it. And if you didn't, you can put any other number besides 1, doesn't matter. All right, good. Now, you know what you're showing me there? Good, we have honest people too. Sometimes when you sit down to study, it is hard to focus your brain. So my job is going to be to help you remember what are the most important things. So you're learning a lot about the central nervous system if this is new to you, or if you already know it, it's a review. But keep in mind, it's those three that are involved in when we get corticosteroids naturally in the body. If you got a 1, give yourself applause. That's super cool. If you got it, that's great. If you didn't, I'm really excited that you're here because that tells me you're engaged, and that's what you need to do for learning. So don't worry if you got it right or wrong this time. All I know is that you are trying. Now, the pituitary anterior lobe puts out all these things, right? You don't need to memorize those. The one you want to pay attention to is the one that goes after the adrenal gland, and that's called ACTH. Let me tell you how that breaks down to adrenocorticotropic hormone. That's the one we want to pay attention to. So it comes from the hypothalamus to the pituitary, and it targets the adrenal glands. Now, here's the other ones that they produce, but we don't have time for those today, but I've got lots of teaching on it on site if you want to take a look at that. But ACTH is going to tell the adrenal gland to produce hormones, all right? Hypothalamus senses there's a problem, sends a message to the anterior pituitary. The anterior Pituitary receives that message and sends a message down to the adrenal glands that says, we need you to produce those hormones. That's how your endocrine system works. Now, it works like that for all the other things. So no matter what you're taking a look at, just understand that the endocrine system follows very specific rules, right? And once you know who starts the cascade, then it's really easy to keep up with how it works and what happens when you have too much of a hormone or not enough. Now let's look at the adrenal glands. Now they're on the top of each kidney. That's easy to remember because it's adrenal. So you can think about this being on top of the renals, the kidneys. So there's one, and they have two parts. So adrenal glands have a cortex and a medulla. Now the adrenal corticosteroids come from the cortex. Now, let's see if you can remember the three organs we talked about in this when we talked about from the brain, two parts that are in your head and one part that's in your trunk. Can you remember those three organs? Okay, now tell me in the chat, give me a why if you could do it faster or you were more accurate this time, that you remembered hypothalamus, anterior pituitary to the adrenal glands. So give me a why if you did it faster or better this time than the last time. Look at that. You're already making progress. All right, and I bet Natalie's not the only one. Oh, yeah, you put out faster. Good. Anybody else? Anybody else faster? There you go. I want you guys to understand that you are making progress and learning's hard, right? And sometimes it feels like it's just never going to be enough, but I promise you, you really can get this. So keep going. And sometimes you just have to be your own cheerleader. Now, the adrenal cortex, we talked about that. That's where the corticosteroids come. This really messes with your salt and water balance, and it's also your response to stress. It's involved in metabolism, the immune system, sexual development, and function. Okay, why does this matter? Well, when we're talking about corticosteroids, and we are replacing, we're giving you synthetic, we're giving you medications that mimic those. Well, here's where we've got an issue. We know that those medications are involved in salt and water balance and stress and metabolism. All those things are going to be affected. Now, what we really want usually when we give corticosteroids, we want to suppress that inflammatory response or the immune system. But sometimes we get all those other things with it. But know that we're going for the adrenal gland. We're trying to get that controlled. Now, I want you to supercharge your memory. Here you go. We're studying together without looking at your notes. What three parts of the endocrine system are represented by these signs? Just say it to yourself. Okay, the guy with the hat and the whistle, he's the coach. That's the hypothalamus because he's the one that's calling all the plays. In the middle, you have the quarterback, the one with the football that's going to send it down the field, just like the anterior pituitary that sends a message down to the receiver. In this case, is the adrenal glands. All right, good deal. Now, repetition is the best way for you to learn and for you to ask yourself questions. I'm doing it with you today just to kind of role model for you, but I promise you, if you're struggling in keeping concepts in your mind, asking yourself questions is 10,000 times better than just highlighting or rereading and reading. That's what you want to do. So we know that corticosteroids are involved in all this stuff. Remember, corticosteroids are because they come from the cortex. So we know the hypothalamus, here's the name of the signals they send. The hypothalamus sends CRH. Its target is the anterior pituitary. When the anterior pituitary gets hit with CRH, it releases ACTH, which tells the adrenal cortex to put out cortisol and aldosterone. Okay, now aldosterone is a hormone. When it's available in your body, you end up with your body hanging on to sodium, and wherever sodium goes, water follows. So when we're looking at the side effects of corticosteroids, I want you to understand what they are. Aldosterone tells my kidneys, hey, reabsorb sodium. Wherever sodium goes, water follows. So you end up having more volume on board. So someone taking corticosteroids is likely going to have some extra volume on board in their intravascular space. We'll talk about that more when we get to the steroids. Now you've got mineral corticoids and glucocorticoids, right? Aldosterone is a mineral corticoid. Glucocorticoids are things like cortisol, and that helps with stress and inflammation. Predominantly, when we're giving medications and corticosteroids, we're going more for the glucocorticoid because we're trying to suppress that inflammation. Okay, so we talked about why aldosterone promotes sodium retention in the kidneys. And the thing with sodium retention is anywhere sodium goes, what follows? Tell me in the chat, wherever sodium goes, what follows? Nice. Melissa got it first, but everyone, excellent. Very good. All right. That's what we're looking for. Okay. So we've got wherever sodium goes, water follows. Talked about the cortisol. These are all the things that it controls. But we're really usually going after suppressing inflammation. Okay, now I call this the sugar daddy syndrome. This is actually a real site. Don't look at it on your own computer. You're going to get some crazy stuff on it. But here's what the danger is with corticosteroids. Now, if someone's got a sugar daddy, that means everyone's taking care of everything for them, and they don't have to do anything for that. Well, when your body is receiving corticosteroids as a medication, your adrenal gland doesn't have to produce them anymore. So it gets kind of sleepy and lazy. So when you're on high dose steroids, usually greater than a week, this is going to become a real problem. Your adrenal gland can become suppressed. Why does this matter? Well, hey, it matters because this is where you'll see it in a test question. This is why you never just stop corticosteroids abruptly. They have to be weaned off. Now, if you just have to take a dose pack for a cold that you've had or some reason that they've prescribed it for you for a very short period of time, you're not going to really see that much of an effect. However, if the patient has been on these medications for a long period of time, they can go through withdrawal. Why? Because when we've provided these synthetic forms of corticosteroids, right, their cortex didn't have to make those, so it kind of gets suppressed or lazy. That's why I call it the sugar daddy syndrome. And then if you stop that medication, the adrenal gland isn't ready to start producing those again. So you'll see some real scary signs, and that's where test questions can come from. So let's see how you're doing. Try and study as you go without looking at your notes, and think about, can you match the hormone with the endocrine player here? So if you're just in your mind, if it's ACTH, who puts that out? Who puts out cortisol and aldosterone? And who puts out CRH? Can you remember? Okay. So at the end, when you see a question like this, you think about, is there something I feel really confident in? Well, cortisol and aldosterone are hormones, and those end up coming out of the adrenal glands. So we can do that. Now you see that the top one says adrenocorticotropic hormone. So that's a message saying, hey, I need you to put out the corticotropic hormones. Then that's got to be the anterior pituitary. That's the message they send to the adrenal glands. And then you end up with CRH is the message sent from the hypothalamus to the anterior pituitary. Now, would you have to memorize this for a Pharm quiz? Maybe not, but when you are studying endocrine diseases, you're definitely going to need to know that. So as we're walking through this, remember, we just got this up here again in case you didn't get to scan the QR code. Remember, this will take you to get the free app that's available to you. We'd love to have you join us with that, and we'll send you stuff through there too. So here's a pre-test question I want you to think about. How would you help keep a patient safe by teaching them about not stopping corticosteroids abruptly? So you understanding this, why you can't stop corticosteroids abruptly, how would you need to communicate that to your patient? Think about how you would say it. So go ahead and think in your mind while we're waiting a little bit here. How would you explain this to a patient? Okay, here's a tip for Pharm. If you think about, wow, somebody I really cared about was going to be on this medication, what are the most important things that I would need to teach them about it? That's going to be where a lot of test questions come from. And if you can explain it in civilian language, right? Language that people, maybe they're not exposed to healthcare, that they could understand it in, that means you understand it, and that's what you're looking for. So Let me tell you how I would practice with this if I was studying corticosteroids. I would help the patient know, like, these medications that you're taking, this is a group of medications called corticosteroids. Now, what they are, these are medications that kind of replace things that your adrenal glands already do. But it's really important that you not stop taking these, because if you stop taking them, we want to wake up your adrenal gland kind of gently. I know when I wake up in the morning, I would much rather just kind of wake up on my own and gently versus a to an alarm clock, right? You wouldn't have to make the sounds with the patient. I'm just doing it with you. So we want to do the same thing to your adrenal gland. When you're on these medications, you're taking them because of, and you would explain why they're taking the medication for whatever process they're trying to eliminate. And then you would say, so as you're taking these, it's really important you take them as directed and you don't stop taking them abruptly. You always contact your healthcare provider, because we want to make sure that your adrenal gland is ready to get back in the game. Okay. Now you could take that script and you could say it however you wanted, adjust it by the type of patient that you have. But I'm taking the concept of, I know this medication causes adrenal gland suppression. If they abruptly stop their medication after being on it for a while, they're going to have an Addisonian crisis, which could be life-threatening. So I need the patient to understand it's very, very important that they take it exactly as it was ordered and they don't stop taking it without contacting their physician. Now, after that, you can communicate it in whatever is your style, your personality, whatever's appropriate for your patient. But that is a great tip in thinking, hey, if my mom was on this medication, what would I want her to know to keep her safe? If you can put it in your own words, you are getting that closer to being absolutely ready to raise your Pharm scores on an exam. So that's a real simple way that you can do it. Now let's do a quick review of these diseases. Cushing's disease is when for some reason, that adrenal gland just goes crazy and starts pushing out all these extra hormones that it normally does. Cushing's syndrome is what you'll see in your patient when we've given them high-dose steroids over a long period of time. Okay, so you have disease and syndrome. You're going to see syndrome a lot more in your nursing career and probably a lot more on your nursing exams. But the signs and symptoms are the same, because this is caused by having an excessive amount of these hormones. Whether your body is making an excess amount or we're giving them an excess amount to try and block inflammation somewhere. But that, you got it. Good deal. So remember, we've got the mineral corticoids and the glucocorticoids. They have different roles. Not so important that you know that right here. And I'll have a chart that I'm going to send to you so you can see that. Remember, we're predominantly going for the glucocorticoid. That's what we're looking for. So you'll see meds there that you've seen before, like dexamethasone or methylprednisone or prednisone. You probably know those names if you've been in practice yet. So we can use corticosteroids for lots of things. I listed things here, but really, it's anything that has an itis or inflammation. Anywhere we're trying to block inflammation, we use corticosteroids. All right, so tell me how the body typically gets the adrenal gland to produce corticosteroids. What's the first organ that notices we need corticosteroids and sends a signal? Can you tell me what the first letter is in that organ? Yes, not, oh, you got all those in. Excellent. It's the hypothalamus. And who's the hypothalamus sending the message to? Yeah, we'll definitely put that scan up again. Don't worry. Okay, now where's the hypothalamus? Anterior pituitary. Fabulous. And then the anterior pituitary sends a message down to the adrenal glands that says, put out the steroids. Excellent. And we're just mimicking that. When we give corticosteroids as medications, we're just mimicking the same types of substances that your body can make. Now, here's what happens when you have too much of this. When you have from head to toe, this is where you have the effect on the body. Now, I'm doing head to toe, and don't make fun of my stick man. I can't draw very well, but that's what I want you to be thinking. Another tip when you're studying pharmacology, think of things always head to toe. So I do neuro, cardio, respiratory, GI, GU, skin and mobility. When I assess my patients, I go head to toe. When I'm thinking through each system to see where they have a problem, I go head to toe. Why? Well, even if you don't have ADHD, Teaching your brain to think systematically is a way to help your brain remember things because you're putting things in your mind in an orderly fashion. And in this case, we know that this is what those corticosteroids do, right? We want to see what's the effect in the body, head to toe, when someone has too many corticosteroids. It might be because we have to give them an excess amount or their body might be making it, but the effects on your body are the same either way. When you're thinking about side effects of medications and other things that you're studying, thinking through, does this medication affect the neural system? Does it affect the cardiovascular system? Does it affect the pulmonary system? Does it affect the GI system? And that includes like the liver and everything in there. And does it affect the urinary, the kidneys? That's a good way to get yourself to make sure you don't miss something. So let me walk you through these, and you'll have these for later, but you can have some really crazy mood swings, right? This could be someone who's really a stable level mood person, but on these medications, it can make you have all these kind of mood swings. It also gives you a moon face, and it can develop facial hair, which men, not a problem. Women, we really, really don't like that. So they can have moon face, facial hair, and mood swings. Okay. Moon face, facial hair, mood swings. Now I'm doing those hand motions just to do something to help you remember. So moon face, facial hair, mood swings. These are results of excess of these corticosteroids, whether it's a drug that we've given them or if they have Cushing's disease. So moon face, facial hair, mood swings. Now look away from our screen and see if you can remember what those three things are yourself. Go ahead and try and repeat them to yourself. It's moon face, facial hair, mood swings. Good. Now you won't have these perfectly memorized by the time we're done, but it's a way of teaching you on how you can study when you're trying to do a lot of side effects, okay? Now let's look at the cardiovascular system. Well, if it's going to have an effect, it's going to cause hypertension. Why? Aldosterone tells you to hang on to sodium, means you hang on to water, and that could cause you to have hypertension. You're going to hang on to more sodium and water, and anytime you increase your sodium, you can also decrease your potassium. That's important for you to remember because that could come up in a test question. So we did neuro and head, right? We did moon face, facial hair, mood swings. Cardiovascular, it could cause extra fluid to be retained, and so you could have hypertension. Now, what about down here in the trunk, GI? Well, end up with rapid weight gain. It happens in their trunk and face, but not in their arms. So they can look like a kind of like a martini olive on a toothpicks, right? That's a classic sign of someone who has excess of these hormones. Can also help them develop insulin resistance, meaning they might have insulin, but they can't use it well. And it tends to raise glucose. So we've got moon face, facial hair, mood swings. Cardiovascular, it could raise their blood pressure if they're retaining extra sodium and water from depending on how much aldosterone is in the medication. Now, when we get to GI, because there really wasn't any impact on the lungs, when we get to GI, boy, you're going to have this really significant weight gain right around the middle, make them more insulin resistant, and it's going to raise their glucose. There are lots of places there that they could ask you test questions, right? So knowing these are the side effects and no one likes any of these side effects, this is where test questions could come from that you would recognize that this could be caused by the medication. Now, these are a little more personal. You have decreased libido. It can also cause impotence, mess with a female cycle, it could cause infertility. These are some extra things that may be dealt with if someone is on these steroids or an excess amount of them for a long period of time. So anybody with Cushing's disease or somebody who's on these steroids a long period of time could also experience these side effects. Again, none of them are things that we would like. Now, there's some other things. They can end up with a buffalo hump on their back, and that's this weird fat padding. They can have acne. Their muscles can have muscle wasting, where they're, like I said, they're going to end up with extra fat here, and they can have muscle wasting, particularly in their extremities. They can cause them to sweat a lot. They can have purple and red striae, which are marks on their skin, and their skin could bruise easily. Here's the deal. That's a lot of side effects for you to go, right? So How do you do this? Anytime you have a large number of side effects that you're trying to recall. Well, all of these are adverse effects, something that could possibly pop up, but it is quite a list, right? I think corticosteroids have one of the longest lists of side effects and adverse effects of many of the drugs that you will ever study. But it's going to take you repetition and thinking through them in the systems as you go. So if you're looking at this drawing, I want you to think about remember we talked about that example, what should you teach your patient about? So I'm going to pause for 60 seconds, be quiet, and see if you guys can think of as many things as possible that you would want to teach your patient. Ready? All right, go. I'm going to be quiet for 60 seconds while you do it. Okay, that was 60 seconds. Now, what I'm most interested in is not how well did you do. I want you to just get used to trying to use this technique. Now, you should look away from your notes, which you may not have had any of this written down, and that's fine because we're going to send you the notes. But causing yourself to pause when you look at some information, pause, look away, don't look at your notes, and see what you can recall. Hey, I've got great news. The research tells you that is going to help you remember that so much better than just looking at rereading, rereading, rereading. Remember, pause, look away, if that's literally or figuratively, but don't look at your notes. See if you can answer a question. That's going to help your brain put that in order and be able to recall it and retrieve it when you need it. So it doesn't matter to me how much you remembered because you're going to have to do this more than one time and eventually you will have it nailed down, right? The most important thing, we're talking about side effects, what's going to put the patient in danger. Of course, the most important thing would be to teach them, hey, don't stop this medication abruptly. But other than that, if I was a patient, I'd want to know about the changes that could happen to my face or to my body or why I'm feeling these huge mood swings, right? Those would be things to be really worried about. What about the change in my glucose? Well, if they're already diabetic and now they're taking corticosteroids, that's a huge deal. So start making these stories in your head on how you would explain it to a patient. And I guarantee you it's going to stick in your mind much better. It's work, but that's good. Because I always tell students, if you're not having to work at learning something, you're not learning it in a way that you'll remember it past the exam, right? Everything in nursing school is cumulative. It builds on the next thing. So it's really important that it stays in your brain in an orderly way so you can get it back out when you need it with your patients and in the rest of your classes. So here's another way you could take the word Cushing's and you could write things like this. That would help you remember it, where you just picked a different letter. Whatever works for you, I want you to do it. And it's not the same tool that works every time, but do things where I call it mental gymnastics. You have to mess around with things to help your brain manipulate it so that you will remember it. And trying to remember just long lists of things doesn't work very long. You can't remember that for very long, but this is another way to represent the type of systemic effects. If you have excess ACTH, remember that's the adrenocorticotropic hormone, which gives you excess cortisol and aldosterone. Whether it's the medication or it's the disease, the result is the same. So however you want to do that, like I would take this picture and see if I could rewrite it, rewrite it, rewrite it, rewrite it without looking at my notes, starting with a clean sheet of paper every time. So there's another way that you can do it. Now, the exact opposite of this is Addison's disease. Okay, so Cushing's disease when you have too much. Addison's disease is adrenal insufficiency. Okay, adrenal insufficiency. Now, here's why this matters. If I'm somebody who's on a corticosteroid and I've suppressed my adrenal gland, if I stop it abruptly, I'm going to show you the same signs as an Addisonian crisis. And lots of test questions can come from here. So if I was somebody whose adrenal gland was just attacked, it's my body's been, it's got an autoimmune thing and it rips it up, it can't function. Or if it's suppressed because I've been on corticosteroids for so long, either way, the result is going to be the same. So an Addison's disease, the worst case scenario, something called an Addisonian crisis, and the body doesn't have enough cortisol, aldosterone, or adrenaline. Okay, think about that. These are involved in all kinds of things. So look at the adrenaline. We haven't really talked about that yet. If you don't have adrenaline, you just don't have any energy, do you? If you don't have aldosterone, think about what aldosterone's role is. Well, its role is to tell my body, hang on to sodium, hang on to water. Okay, so if I don't have aldosterone, am I going to be dehydrated or am I going to be fluid volume overloaded? Think about that. If you remember what aldosterone's impact is, tells my body to hang on to sodium, and wherever sodium goes, water follows. If I don't have enough aldosterone, am I going to be really dehydrated or fluid volume overloaded? What do you guys think? Can you guess in the chat? Come on, get out there and just try and guess. I promise I'll tell you the right answer and we'll explain it why. Research tells us, because that's what I'm fascinated with research about your brain, just trying to answer a question helps you learn. It's not as important if you get it right or wrong. It's how will you learn? Okay, in this case, if I don't have enough aldosterone, then I don't have that stimulation to retain sodium and hang on to water. So I will be dehydrated. That's what you're going to see with Addison's disease. All right, good job. Whether you get it right or wrong, I'm just proud of you for trying and getting out there. Love it. Okay, so in Addison's disease, if it's not caused by, it's an autoimmune thing that can happen. The other thing is there could be a problem with your anterior pituitary gland, but predominantly it's going to be that the adrenal gland has been attacked by your own immune system. And unfortunately, it usually isn't caught till most of your adrenal gland is just completely knocked out. So let's look at the side effects head to toe, right? So neuro, they're going to be really chronically fatigued. Can you remember what they're missing and why they're chronically fatigued? Can you remember the name of what they're missing? If your adrenal gland can't put it out, why they're chronically fatigued. Let's see if anybody can get it. What are they missing? It starts with an, yes, look at that. Veronica and Joel got it. Yes, Natalie. Woohoo! Good job. Well done. Well done. So people can also write this into test questions, right? They'll say, what if you know you have a client who has known Addison's disease? They'll ask you, which of the following symptoms are important that the nurse follows up on? Well, if the patient who has Addison's disease tells you they've been feeling really tired, that's definitely one you would want to follow up on. Flip it the other way. What if a patient has been taking high-dose corticosteroids for a number of years? Which indication would tell you that the patient had abruptly stopped their medication? If they show you any signs of Addison's disease, because that means they're on the high doses, their adrenal gland was suppressed. If they are not continuing to take their medication, they abruptly stop it, they're going to show you an Addisonian's crisis. So you can see how they can, I would love to get feedback from you. Is that making sense when I help you with the test questions? Would you mind just showing? We'll have it recorded for you, no problem. Is it giving you the test question examples? Is that helpful to you guys? Do you want me to keep doing that for you? Give me a yes in there if you want me to still keep showing you how. Okay, good. All right, just making sure. Good. I don't want to do anything that's not helpful to you. Okay, now in the other one, if I have excess corticosteroids, remember I had high blood pressure because I had higher volume. Well, this is the opposite, which is just how endocrines work. Exact opposite of each other. So since I don't have enough, I'm going to be dehydrated, which you already guessed. I'm going to have a lower sodium, which means I'll have a higher potassium, and my blood pressure is going to be low because I don't have enough volume, right? Well, in my body, anytime I have low volume in my intravascular space, my heart's going to go fast to try to move it around faster. All right, that's why you're going to have tachycardia. tachycardia. That's a fast heart rate. So these effects are the exact opposite. If you saw any of this stuff in someone who had taken corticosteroids for a long time, long enough to have adrenal gland suppression, and they're showing you this, you know you're in trouble right away. Now, some other weird things, they're going to crave salty food. They're going to have GI distress. Might have some diarrhea and hypoglycemia. These are the opposites of the corticosteroids. They were really hungry. These guys, ugh, they're not interested in food at all. So another way to study is to just put these right next to each other. Now, with adrenal gland insufficiency, also going to mess around with your muscles, are going to have weakness. But remember, it's the Addisonian crisis that is a huge problem. So most often you'll see an Addisonian crisis when the patient whose adrenal gland has been suppressed stops taking corticosteroids quickly, right? They just abruptly stop it. So that's what you want to be on the watch out for. Now, here we go again. Let's see what you can do. And remember, just try, because that's going to help you no matter what. So without looking at your notes, what do you remember about an Addisonian crisis? I'm going to give you about 30 seconds to see and list in your brain, going head to toe, what can you remember? Remember, this is an adrenal gland that's not functioning. You're welcome. Thank you for being so kind. Yeah, Anna, that's a good one. Ooh, nice, nice, nice. Excellent. Some of you guys are even sharing in the chat, and that's fantastic. Ooh, Hershey got a whole list of them. Even got fancy with the low sodium and the potassium. Woohoo! That's a hard one to remember. You got it. Okay. Gosh, you guys, this is like the best part of my afternoon is when I get to spend it with nursing students. I love it. Yeah, you're doing great. Here's some answers, some things to think about, but you are nailing it in the chat. Thank you for sharing that. That helps all of us be excited. Yeah. And if you didn't get all those, don't worry about it. Remember, you're going to go back. You're going to have these notes you can review. That's how you're going to win it. So remember, in an Addisonian crisis, if you're treating it, no matter what the problem is, if they have Addison's disease or if they abruptly stop their corticosteroids and their adrenal gland was suppressed, you can't save them unless you add steroids. So an Addisonian crisis is an adrenal gland that can't respond. You need to add steroids that adrenal gland normally does. So you want to watch for signs of patients getting into crisis, and you know what those are, right? And then you're going to have to replace those steroids. You're going to replace that cortisol and whatever else they might be missing. And always make sure when you're with a patient or when they're not with you and they're still taking it, they know steroids need to be tapered, right? Not abruptly discontinued. They have to be tapered. And also think something to keep in mind, if their adrenal gland isn't working, like it's suppressed, or they have an Addison's disease, if they have extra stress in their life, they're going to need extra steroids. So they need to understand, hey, if you start feeling really tired, any of these symptoms that you see with an Addisonian crisis, they need to contact their healthcare provider so they know they might need to adjust their dosages for a while. So it can be a psychosocial factor. They can be in stress in their family or financial stress or working multiple jobs or, I don't know, in nursing school, or if they have surgery or pregnancy. Those are things that could really throw them off, and they might need to have their medication adjusted. All right, let's try it one more time. You're doing so good. I'm going to give you this where you can compare them. So if you can go down head to toe, I'm going to give you a minute to do this. Head to toe, the signs and symptoms, they should be the opposite between Cushing's or Addison's. Okay, isn't that cool? Like, look, you've learned corticosteroids, you've learned how this works, right? You've learned that HPA axis, you heard called that. You've learned Cushing's disease, Addison's disease, adrenal. I'm sorry. Oh, sorry about that. Um, you get to meet my schnauzer. I didn't realize she was there, but now we know she is. So Harley, say hello to everyone. Thank you. Yeah. Yes. All right. I'm so sorry. Cushing's and Addison's disease, just opposite of each other. So you think about you've just invested less than an hour and you've learned about corticosteroids. You've learned how the adrenal gland works. You've learned how the adrenal gland knows when to put out certain hormones. You know what to look for if somebody stops their medication abruptly. You know how to teach them. You have done the work of learning a ton of things already. And you got to meet Harley, the amazing schnauzer. So now, how would you answer this question? I want you to see if you can do this again. How would you help keep a patient safe by teaching them about not stopping corticosteroids abruptly? Do it in your own mind. You can do it quietly. What would you tell them? Okay, hopefully you took the time to try to go through that because I promise thinking about how you would educate a patient is going to really make that. And plus, that's what we're all about, right? But it's also going to help you remember the key things about medications that could show up on an exam. Now, we often at discharge of patients just print out a bunch of papers and hand it to them. That's really bad. That's really bad strategies, right? If that worked, we would all be geniuses because we have textbooks. You need to help make this matter to the patient, help them understand why it's important that they have this information. Don't just tell them, do this, don't do this, do this, don't do this, do this, don't do this. They need to understand why it's important to them and how they can be successful in doing it. Same thing about us when we're trying to learn things in nursing school. We need to know why it matters. So I always recommend for students, whatever you're learning, try and think, why would a nurse need to know this? And how would it help me keep a patient safe? That's way more important than how do I memorize this list of side effects? It's like, okay, why would I need to know this about this medication? How I would use it to keep a patient safe is either I would educate them about it, I would recognize the symptom early and I would do something about it, make it real and how you're doing it. Okay, let's do a question. All right. The nurse assesses a client's at-home medication compliance. Now, Mr. Baird is a type 1 diabetic and has been prescribed a lot of meds, albuterol, lisinopril, methylprednisone, and fluorocortisone for 10 years. Which of the following patient statements requires immediate follow-up? Okay, now when you're looking at a test question, we got a lot going on here, right? We got a lot going on here. So here's how I'd break it down. Okay, I know I'm looking at their at-home medication. I got it. I know things that are particular about this client. Well, his name is Mr. Baird, and he's a type 1 diabetic. So I know he already has blood sugar challenges. He's on insulin, but he's on albuterol. In case you don't remember what that one is, that's a bronchodilator for respiratory. Lisinopril, that's for the cardiac for hypertension. And we have a whole series on getting ready for the cardiac meds that are on the site if you want to take a look at it. Remember, you can do that free on the app. Look at some of those too. Methylprednisone. Oh, there we go. Now we got some corticosteroids and fluorocortisone. All right, there's another steroid. And he's been on it for 10 years. So it's asking me which of the following patient statement requires immediate follow-up. Well, right now, before I look at this, I don't know, right? It could be with any of those medications, but it says, Mr. Baird says, I've noticed that my face looks a lot fuller since taking my medications. What about my heartbeat is faster and I feel shaky when I stand up? I use my inhaler when I feel short of breath after walking, or my blood sugars are difficult to control and I'm requiring more insulin. Okay, your job is I want you to go through those answers. I'm going to give you a minute and you can eliminate each answer, say why to get down to your best choice. Ready? Okay, I'm going to give you a minute to do that. Got about 20 more seconds. Okay. I'm going to tell you things that we can eliminate. Now, when you're looking at the answer choices, and I do a whole series on test taking strategies, that's also available. We've done some things with Sigma too, so you've got those available if you want more practice at that. But you don't have to start at number one. You can eliminate as you think. Now, number 4, that's the one I'm going to get rid of first. Here's why. My blood sugars are difficult to control. Well, that's because of, it could be because of the disease or the medications, and I'm requiring more insulin. Oh, okay. Well, they're difficult to control, but you're using more insulin. That doesn't mean the patient's in danger. So I'm okay. Number 3, I use my inhaler when I feel short of breath after walking. Does that require immediate follow-up? No, that's when they should use it. Okay. So between number 1 and number 2, both of those will be affected by corticosteroids, right? Face looks a lot fuller. Well, we could explain to them why. It's because of the medication. But number 2, my heartbeat is faster and I feel shaky when I stand up. All right, which one of those is the biggest deal for immediate follow-up? Well, if you put number 2, you are correct, because this means this is a sign to us that the patient might not be taking their medication correctly. If their heartbeat is faster and they feel shaky when they stand up, that might be because they are volume depleted, which is a sign that that adrenal gland is not working, right? So we know that this person doesn't have Addison's disease, but he's been on this medication for so long, they have suppressed their adrenal gland. And for some reason, whatever they're going through, it's not able, the dosage that they're on is not enough. So if you guess number 2, you got it. If you guess number 1, that's okay. I want you to celebrate because you picked up, hey, that's a problem that's linked to the corticosteroids. But here's the deal. You're going to see questions like that all the time, but you're always going to ask yourself, for this particular patient in this particular setting, what will keep them the safest? Can you see how number 2 is a bigger safety issue than number 1? Both of them require follow-up, but number 2 is the biggest safety risk. Okay, if that makes sense to you, why number 2 is the best answer, can you give me a Q in the give me a Q in the chat if that makes sense to you? Excellent. Thanks, Anna. You got it. So if it makes sense to you, why number 2 is the correct answer, give me a Q. Look at that. You guys are on it. Fantastic. Good job. Now, don't get frustrated because, man, questions are hard. They are hard. Now, we're going to switch gears. But before we go into IV solutions for our last part of this session, I want you to close your eyes for the next 30 seconds and think about 5 things you just learned. All right, just think, let's see if you can list up 5 things that were new to you. Ready? Go. Okay, excellent job. Now I want you to think of and write down, what is something you want to be sure to review again? You feel a little shaky on it, didn't make sense to you. What is something you want to review again? Write down 1 or 2 things. Now, if you will do this with every study session, if you stop and pause and remember the things that you learned, you're going to tell your brain, I am capable of this. And you're going to remind yourself, oh yeah, I did learn this in this session. The second habit, if you will write down where you need to start studying the next time, this is why it's brilliant. You only have a certain amount of energy and brain time and just time in the day to study. So you want to get the best out of it. So by writing down what you need to review next, then you know when you sit down to study again, that's exactly where you start. You will save yourself a lot of time and frustration. A lot of times students just kind of study willy-nilly and they don't really know where to start and they just feel overwhelmed and all they see is all they have to learn. That will never help you like this will. Reminding yourself of what you learned and what you need to brush up on next is brilliant. Another thing is a study guide. We'll talk about that later in another session, but organizing your study is the best way to make it effective because it's hard. And if you're going to invest time in studying, you want to get the most out of it. So let's talk about IV fluids. Now, first of all, you have to understand like fluid and electrolytes. It is not as hard as people sometimes make it out to be. Again, this is another thing that sometimes we just made a bigger deal out of it than it is. But I want you to be thinking about you sitting right there in all your squishiness. You're about 60% extracellular fluid, right? So 60% of the total fluid is extracellular, 40% of it is intracellular. Now, when we say extracellular, that means it's outside of the cell. If we say intracellular, it's inside the cell. So just start with this at the top. We've got two places fluid is initially. It's inside the cell, it's outside the cell. If it's inside the cell, it's called intracellular. If it's outside the cell, there's two places it can be, interstitial or intravascular. So intravascular means inside your blood vessels, your arteries and veins. And remember, that's where we get your blood pressure. Now, I always teach students that blood pressure is the pressure of the fluid inside the vessels pushing on the veins and arteries. Okay, so blood pressure is the pressure that the fluid pushes against the vessels. Blood pressure is the pressure that the fluid is pushing against the vessels. That matters because if I have less fluid in my veins and arteries, my blood pressure, is it up or down? Tell me what your blood pressure is, it up or down? If I have less volume, that means what I will have less pressure pushing on those vessels, so your blood pressure will be down. Okay, good. All right, I love it. You guys are guessing. That's fantastic. Woo, we went for a ride there, didn't we? All right, so two places fluid can be in your brain. What's the first level? Two places that fluid can be. It's either in the or out of the What's the word? Can you write it in the chat for me? It's either in the or out of the two places it can be. You got it. Ooh, cellular. So it's either inside the cell or it's outside the cell. If it's inside the cell, we call it intracellular. Now, where are the two places outside of the cell? You guys are I love it. You're so proper. You write out full sentences. That's great. You don't have to, though. You can just write short words. If it's outside of this, interstitial and right, intravascular. Perfect. Yeah, and those are hard words to spell. Nice. You guys are on it. Oh, I hope you come to our other sessions. You're fun. Now, when it comes to IV solutions, there's three types. Now, first, I want you to focus on, don't look at all of that. Let's just focus on the words. Isotonic, ISO. Iso means equal. Hypo, HYPO, hypo means what? Does it mean higher or lower? What does hypo mean? Less. Perfect. See how much you already know? So what does hyper mean? If hypo means lower, hypo means higher. You've got it. All right. Now, think of this as concentrations. So we want to think about, in a normal setting, it's going to be about the same. Your blood, the fluid in your blood and your cell are going to be about the same tonicity. Okay. Think of it as like concentration. Now, sodium is the electrolyte. Remember, an electrolyte is something that has a charge. Sodium is positively charged, right? And it's the most prevalent one that's in your bloodstream. That's the most prevalent electrolyte in your bloodstream is typically sodium. And we all know where sodium goes, water follows. So if things are about equal, if I give you an isotonic solution like normal saline, 0.9% normal saline has the same tonicity as what's in my bloodstream. So if I give you that, fluid shouldn't shift. Because remember, fluid is either inside the cell or outside the cell. Now, it's the ones in the intravascular space that controls my blood pressure. But if I put an equal or an isotonic solution into an IV, into my vessels, my intravascular space, then I'm not changing anything, and fluid should stay where it's supposed to stay. It shouldn't shift from the interstitial space or the cell. It should just stay where it's supposed to be. But now we've got these other two groups, right? It's either equal in tonicity or it's lower in tonicity or higher in tonicity. So what's going on there? Well, if I hang a hypotonic solution that is lower tonicity than what my bloodstream is, now we've got a problem. I'm more concentrated in my bloodstream or in my cell. Well, since I hung a fluid that has lower tonicity, now I am more concentrated. Stick with me. Now I'm more concentrated. If I hang a lower one, I'm more concentrated in the cell. Now, hopefully that makes sense to you. So we will fix this. So when we're talking about osmolality or osmolarity, they're the same thing. So I don't want you to worry too much about words. Think about concentration as if I was putting like a drink mix in a glass of water. If I put, there's not enough water, it's really strong, right? Think of that as being hypertonicity. So osmolality, osmolarity, let's not get messed up in that. Just thinking about the concentration of the sodium is what's going to matter to you. So isotonic solutions, we gave you a list there. You see there is normal saline, right? That's one that we give that's isotonic, but also it can be things like D5W, lactated ringers. We'll send this list to you. It'll be in your notes. Don't worry about it. Hypertonic those are examples, D5.5 normal saline or D5 normal saline. Those are considered hypertonic. Now you see the numbers at the top. We've got like 300 mils and 270 because normal in your normal osmolality in your blood is 270 to 300. And that's where those medications right down the middle fall, those IV fluids. But the ones to the left are lower. They're hypotonic solutions. The ones to the right are hypertonic. So the takeaway is you can hang an IV fluid and cause someone's blood pressure to tank, right? You can overload them. IV fluids, we give a lot of them, but you have to be really careful with them. I always tell my nursing students, when you hang an IV bag, I want you to see my face through the other side so you know that there is no such thing as a completely safe IV fluid. If you're hanging IV fluid volume, you could cause shifting in or out of that intravascular space. You could damage the cells, or you could end up really messing up with their blood pressure. You can do big things. So always be very cautious whenever you're hanging an IV solution. But let's talk about the way that fluids are going to go. If I hang a hypertonic solution, you can write this down. Wherever it's hypertonic, fluid will be drawn where it's most hypertonic. So when it comes to hypertonicity, fluid will always be drawn to where it's most hypertonic, more concentrated. When it comes to fluid volume shifting, fluid will always be drawn to where it's more hypertonic. So if I hang a lot of hypertonic solution and I put it in an IV, now I'm more concentrated in the intravascular space. So it's going to take fluid from the cells and shift it into that space. Okay, so if we have a hypertonic solution and I put it in the intravascular space, now I am stronger, more concentrated in that intravascular space. Fluid is going to shift from the cells into the intravascular space. So I end up with more volume in the intravascular space, less volume in the cells. If I hang too much of it, that could be a real problem for the cells. Now let's look at the exact opposite. If I hang a hypotonic solution, that means it's lower, right? So now the bloodstream is not going to be the most concentrated. Inside the cell is going to be the most concentrated. So the intravascular space is going to push fluid into the cell. Now, why is that a big deal? Well, it's a big deal because if you hang that solution, remember now I've hung hypotonic solution in my intravascular space. I'm more concentrated in my cell, right? So fluid is going to shift from the intravascular space into the cell. The cell's going to swell. Now, that's not really good. That's edema, right? And one of the places I'm concerned about is the cells in your head. Because if those cells in your brain swell, then you're going to elevate intracranial pressure from cerebral edema. So If you're ever hanging a hypotonic solution and the patient tells you they have a headache, stop, find out what's going on. So let's go through this again and see what you think. I'm going to ask you some questions. If I hang isotonic solution, will fluid shift out of the cell into the intravascular space, or out of the intravascular space into the cell, or should it not cause fluid shift at all? Yeah, good. So we would use this to replace volume. I'm so impressed with you guys. That's not an easy concept to get, and look at you. So if you're struggling with a little bit, it'll just take you time. I promise it's okay, but you guys got it. Now let's hang a hypertonic IV solution in the intravascular space. Is that going to cause a fluid shift? So first, just tell me yes or no. If I hang hypertonic solution in the intravascular space, will it cause a fluid shift between the cell and the intravascular space? Yes, it will. All right. So who's going to donate fluid? If I hang a hypertonic solution, are the cells going to donate fluid, or is the intravascular space going to give up fluid? Who's going to do it the most? Nice. I'm so impressed. Hey, listen, if you're struggling with this, you're with the majority of us, okay? But it is, if it's hypertonic, the cells are going to give up fluid because they're always trying to find balance. Okay, now let me ask you this. What type of fluid will cause fluid to go into the cells and swell up and cause that edema? What type of fluid will cause that? Nuh-uh, no way. Look at you guys. Oh, please promise me you're going to come back for the rest of our series on stuff. You're getting it. And again, if you don't have it yet, it's okay. Look at these guys and know that you will. You will get it. I am so excited. Yes, yes, yes. Great. So you're doing a lot of hard work here. I'm really impressed. And remember, let's go over this again. Isotonic solutions, that osmolarity, the tonicity is right about the same as your blood, between 270 and 300. Now, for those of you, this is just a little extra credit. You can kind of tell what your patient's intravascular volume status is if you just take their sodium and multiply it by 2. You know that a normal sodium is 135 to 145. So a little trick, if their glucose isn't off, their glucose is within normal, you just multiply their sodium by 2, and you know roughly what their current blood osmolality is. It's just kind of fun to take a look at it. Ask your faculty to go over that with you. So remember, isotonic solutions are equal. And we give this because we want to just put more volume in the intravascular space in the vessels, because we usually want to raise their blood pressure because they don't have enough volume and they're pushing against the vessels to help everything be what it needs to be to deliver. So you give an isotonic solution in the intravascular space, and you're meaning for all of it to stay in the intravascular space. Shouldn't cause fluid shifting unless you give them too much fluid. So if I take a little 95-year-old grandmother and I give her 4 bags of solution, that's going to overload her and could throw her could cause hypertension, congestive heart failure, can almost start functioning like a hypotonic solution. So the isotonic solutions given in the right amount for the patient should keep fluids just in the intravascular space. Okay, gave you a list there. You've got them again. Remember, you're going to get all these notes, no problem. And this is why we would use normal saline or a hypotonic solution for things like shock, because we want to increase the amount of blood, the circulating volume, because it's delivering oxygen and nutrients to your cells and tissues. So you will see this given when someone's in shock. That means their blood pressure is not high enough, particularly like in a hypovolemic shock. If someone's in DKA, we give all kinds of different fluids, but this is one of them. If we're giving a blood transfusion, normal saline is the one to give with it. If they have low sodium, we could give them some normal sodium, normal saline. If they're in metabolic alkalosis, we could give it, or if they have hypercalcemia. But the biggest one I would remember, that's a really long list, and you'll get into more of those if you haven't studied these diseases yet, but know that, yeah, I'm going to give it to somebody who theoretically doesn't have enough volume in their intravascular space to support their blood pressure effectively. But you're also going to watch them very closely for signs of fluid volume overload. Now, what is a sign of fluid volume overload that I can assess with my stethoscope? What's a sign of fluid volume overload that I can assess with my stethoscope? Can you tell me in the chat? Nice. Crackles. Perfect. Right. Because the crackle sound could be a sign of pulmonary edema. Bomb. You're doing the bombidity. Now remember, this patient, this has sodium in it, obviously, because it's normal saline. So you want to be careful if they have kidney disease, renal disease, or glucocorticoids. Fantastic. Now, something cool about lactated ringers, the liver converts the lactate to bicarbonate. So if somebody has liver disease, this is not a great choice for them. So this would be somebody, just a kind of a fun fact for you to know that the lactate in there is converted to bicarbonate, but a patient whose liver is not working really well can't do that. And you also don't want to give it to somebody in alkalosis. Remember, if their liver is working, they're going to convert the lactate to bicarbonate. And if you're in alkalosis, your pH is already lower than 7.35. So we don't want to give you more things that will convert to bicarbonate, which will make that, oh, I'm so sorry. If you're in alkalosis, your pH is greater than 7.45, right? Alkalosis is a pH of greater than 7.45. Acidosis is lower than 7.35. So if I have a patient who's already with a pH greater than 7.45, if I give them lactated ringers, their liver is going to convert that into bicarbonate, which is going to make their pH go even higher because that's a buffer. So we can give it to people who aren't in a big crisis like that. It's often given as a fluid and electrolyte replenisher, and it is fairly safe as long as you keep an eye on, do they have any problems with liver disease, and what is their pH if you think that is pertinent. Now, D5 in water's got some really tricky things going on. It's isotonic in the bag, but once you give this IV, the dextrose, once that dextrose is metabolized, it happens pretty fast, then this becomes hypotonic. So it's kind of both, right? Before you give it, it is, and initially when you give it, it's isotonic, but once that right, the dextrose in there, the D5, once that's metabolized, it becomes a hypotonic solution. So you don't want to give this one to people with elevated intracranial pressure, because remember, intracranial pressure could be a sign of cerebral edema, because once you give a hypotonic solution, then fluid is going to rush into the cells and swell. But here's some other reasons we give it, but you can give it for fluid loss and dehydration, but you just want to know what else is going on with your patient. Hetastarch and Normasol, you probably won't see these very much, but these are called volume expanders. They're isotonic. We're just trying to give that if someone doesn't have enough volume. It can't carry oxygen, but it will help with their volume. So hypotonic solutions, this is who you don't want to give it to. How you might see as a test question, it'll say, which of the following physician orders would require immediate follow-up by the nurse? If you have a patient who has a head trauma or has had a stroke or neurosurgery, or we know has elevated intracranial pressure, we don't want to give a hypotonic solution. Can you tell me why in the chat? Why would we not want to give them a hypotonic solution? What's the big deal? See what you can think. It takes a little bit. Why do I not want to give somebody who has elevated intracranial pressure a hypotonic solution? Think about what happens when you hang an isotonic solution. Which way does it cause fluid to shift? If I put a hypotonic solution in your intravascular space, it's going to cause fluid to shift into the cell, right? And when it causes the cell to swell, if they already have elevated intracranial pressure, that could make it worse. You also don't want to use it with people who like burns or trauma or have a low serum protein, because it can just make everything worse. Yeah, good. That was a hard one. You guys did great. Here's a list of the solutions. You can use half normal saline. Here's some examples of when you use it, and you might be thinking like, wow, this has been an hour and a half. So if your brain is kind of struggling, it's okay. You put a lot of work in, but we can use this for DKA after we've done the normal saline and before we do the dextrose and solutions. Now that's a pretty quick summary of a complex thing. So if that doesn't make complete sense to you, it's okay. If someone's lost a lot of lost a lot of gastric fluid because they've been on long-term NG suctioning, this might be something we consider. And you can also give it if somebody has had a hypertonic dehydration, meaning they've lost way more water than they lost salt. So we're trying to bring that down a little. You won't give as much of that. But remember, you don't want to use this solution for burns, liver disease, or patients with trauma. Okay, with the hypertonic solution, you know that it's going to cause fluid. We hang that in the intravascular space. That is going to cause fluid to shift from the cells and the interstitial spaces into, right, the intravascular space. Now, we use these sometimes to replace electrolytes. We use it after post-op because that would be good. We want to decrease the risk of edema. It can also help us stabilize blood pressure and regulate the urine output after surgery. But that's what hypertonic solutions do. So I'm sure if you've been in the hospitals, you've seen a lot of D5 half normal saline. That's a hypertonic solution. So it's given a lot, but just keep in mind what its purpose is. Now the D5, this is also another one that's used with DKA, but remember, that's pretty complex. We have other videos on that. Just an idea if you know that we use it, and it'll help us minimize the effects of if we have a really quick decrease in their serum osmolality. When someone is in DKA, diabetic ketoacidosis, they have super high glucose levels, which also messes with the osmolality. So this will help us address that. Now D5NS, this will cause, we can use it for someone has, these are some pretty fancy things. So if you're familiar with this is going to help you. If you're not, don't get, as I say, lost in the weeds. I just listed these here in case you were curious, but I wanted you to know that it was available and what we would use it for. Now, this would be something we could use in an Addisonian crisis because it's going to help us deal with that salt loss. Okay. Fabulous. Now, you don't want to use this with patients with renal issues or CHF because it might have this increased risk for fluid volume overload. All right, D5LR. Remember, this is the one, the LR, where the liver converts the lactate to bicarbonate. And if the patients have liver disease, it won't go well. You don't want to give it to somebody with alkalosis because the liver converts it to bicarbonate, which will mess with that pH. And we can also give this as a fluid and electrolyte replenisher. Now, this is a lot of information. I wouldn't expect that you take this all in one day, but let's see what you have learned because I'm pretty sure you have a lot of this in your mind. So 3 types of IV solution, and it ends with the word tonic. So what are the 3 types of IV solutions? And you don't have to write it in the chat. You can just see if you can say it in your mind, or you're welcome to write it in the chat. Nice. Nice. So we've got equal, which is iso, and then we have low, which is hypo, and which is hyper. Perfect. All right, good. And you know that each one of these has a role to play in causing fluid volume to shifting and an impact on blood pressure. Now, instead of naming 2 IV fluids, I just want you to say what type of fluids will cause volume to shift from the cells into the intravascular space. What type of fluid will cause fluid volume to shift from the cells into the intravascular space? Can you think? Yeah, just go ahead and put an answer out there. Step out, be bold. That's where you learn the most. From the cells into the intravascular space. Remember, fluid is always moving towards a hypertonic place. So if you hang a hypertonic fluid, that's going to cause fluid to shift from the cells. Okay, good. I love it. You guys are putting answers out this. Now, you can go back and fill this in when we send you the notes. You've got it there and you can kind of practice that. You know that somebody who has an intracranial pressure problem, a stroke, a head trauma, we don't want to hang any fluid that will cause the cells to swell. You got it. All right. Now we're coming up almost to the end here. We've got a list of things coming up. On November 19th, I'm going to do an NCLEX review class, and we have a full NCLEX product. Remember, we're really proud to be the Sigma Nursing's exclusive NCLEX review provider. On February 12th, I'm going to do something about just taking care of yourself, and I promise it will be practical. I'm not going to sing Climb Every Mountain. I'm going to give you things that can really help you survive in nursing school. I know personally, I wanted to quit nursing school legitimately 3 times and almost did. Then March 12th, we're going to do some more NCLEX stuff, and we've got some special things just for people exclusively who are connected with Sigma, and that's you if you're here on this presentation. And April 1st, I'm going to talk about common NCLEX misconceptions, really weird stories that you've heard about, and we'll send you reminders about all of these. Now remember, we are Lecturio. We're a partner with Sigma for our NCLEX review. We have all kinds of things, resources, video libraries, practice questions, a full NCLEX review class. We've got quizzes. We have an AI tutor that can even help you learn more about answering questions. Sign up for this right here. I'm going to leave it on the screen for a bit. When you do this, there's the Apple one and there's the Android one. If you will sign up here, just use a QR code, it'll take you to the App Store. I promise they do not ask for your credit card. I hate when that happens, right? But you can also sign up for an account. I'm going to give you a 50% off coupon in just a minute. But here you can get cheat sheets. You see those over there on the left. They're pretty cool. They're nice and pretty and graphical and lots of information that you need. So it's got one pagers and also tell you a great video link is on the bottom. You got the access to free videos. You've got the recall questions. You got all kinds of free stuff available to you just through the app. Now, if you want more than what's available on the free app, here's a coupon for you. Here's another QR code. And I'll keep going through these back and forth so you can kind of see these, whichever one you want. But this one will give you 50% off because you are a Sigma member. We're running a special. The B2C guys, the marketing guys are running a special and wanted to make sure that I shared this with you. Now, usually Sigma people like you guys who come in because you got a Sigma invitation, you get 40% off, but now we're running it even higher because we know October is a very hard month, right? It's after midterms. The finals seem a very long way away. Working with Lecturio and using our app is going to help you get ready for your finals. It's a great tool for that. If you like today's kind of teaching, that's all over our website because we're all interested in helping nursing students understand better. And we take complex things and make them simple. And you get access to all our PowerPoints, our recordings. It's translated into over 35 different languages if you prefer to see the closed captioning in different language. So we really want to help you study. This is the QR code that will give you 50% off of that. Here's back for the QR codes to sign up for the app. You've got them there, Apple on the left and Android on the right. So if you're a Google or Android person, you've got just as much access as the iOS people. I have a Pixel phone, so I'm with you Android people, but Apple's cool. I also have an iPad too. And then here is the code for the 50% off. Remember, that's a big deal. And it really is limited time. They're not just making that up. Unlike, Guns N' Roses on their final tour again, but you guys probably don't even know who Guns N' Roses is. All right, man, we so enjoyed spending time with you today. If you want us to come to your school, we'd love to. Come and bring something special to your school. Here's another QR code. Apparently we have lots of them, but we would love to bring a session to your school, whether it's virtual or in person. We'd love to come and do an NCLEX review at your school. Just tap in and let us know what you'd be interested in, and it would be our pleasure. We're going to NSNA, if you're involved in your National Student Nurse Association or a chapter in your school, we are partners with them too, and we go and visit there. Now, Sigma will also be there in April, so if you come to NSNA in April, you need to make sure you go to the Sigma booth, and I think we're going to be real close. Lecturio and Sigma booths are going to be right by each other, so come by because we always give super fun giveaways, and we're just fun people to hang out with, and we'd love to get to meet you in person. So if you have any questions, please let us know. You've got the QR code. We really are thankful for you to come today. Oh, thank you for your kind words, Hershey. That means a lot. We want you to have a good time, and we are getting very close to the end of our time. We always want to end up on time, but please let us know how we can help you, and I hope you join us again. I'm going to turn this back over to my friends and colleagues at Sigma in case there's anything else they would like to say before we go. Bye, everyone, from my part, and thank you for coming.
Thanks, Dr. Laws. As always, you're so entertaining. As she mentioned, definitely join us for one of our future sessions and we'll be continuing to promote those as well on social and via email. So you can always check those out. So thank you, Dr. Laws, for sharing all of this great information, and we appreciate you taking your time today. We hope you've enjoyed the webinar. And as a reminder, we will send an email within a week of the webinar with a link to the recording. So that way you can check that out. So just look for that, Josie, and then you can review all this wonderful information and catch up on that. So thank you for taking the time, and we hope you have a wonderful day.
Bye, everyone. Thanks for coming.